welcome to Our Experience, ASCP's podcast. I am your host, Chad Wurz, Chief Executive at ASCP, alongside my hosting partner, Tom Hansel of Hansel Health. And we have a special episode today. It's Inauguration Week, and we've got our key people that keep us informed on elections. A number of you as members have certainly seen them speak in front of our audiences before. I've got Jim Flood, who was a former, I don't know what your title was with Chuck Schumer. Counsel for Chuck Schumer. And Scott Douglas, who was former counsel for Mitch McConnell. So we've got the two leads on the Republican Democratic side with their experience with regard to those individuals. And they also both worked at Omnicare for a long time in the early 2000s, I think until 2012. So a lot of experience from a long-term care perspective, and we're really going to get into the details around what's going on in Washington with respect to PBM reform, with respect to IRA, and what this new administration and Republican Congress and Senate is going to do in healthcare in general. So thanks for being here. Appreciate it.
Pleasure.
Yeah, thanks for having us.
Why don't you start off, just give us a little, like, what do you guys do? What are you doing now? Like, what is your role at Crowell and Moring? You're both counsel at Crowell and Moring. What are you doing now?
We're both senior folks in what we call our government affairs group. So Scott and I spent a lot of time with healthcare clients and other clients basically figuring out Washington is the way I would describe it. And I don't think there's been a year that I've seen in the last 10 years that is as complicated to figure out as this year, 2025. The election of President Trump and obviously the Republican takeover of the Senate and the House now really means that the president has just a clear runway to move considerable legislation. And not only that, but this spring, he's made clear, and the Congress has made clear, they're going to use a vehicle known as a budget reconciliation bill that only requires Republican support if they all line up together. So it's getting really interesting, whether it's, tariffs is a huge issue. In the medical space and outside the medical space, there's tremendous fear. There's a misunderstanding about what's going on. It's very difficult. With regard to, our healthcare clients, there's, there's positive stuff, some questions depending on your perspective, like it looked like PBM reform was close last year, maybe this year, but there's also concern as in, well, wait a minute, if we're going to be in a tariff war with China, what if the Chinese get really serious? What if they wake up one day and say, you know what, no more API for you. We're not going to help you make good drugs anymore. Like, you want to play tough with us? We're going to play tough with you. So that's a lot of what we're doing. And again, 2 more weeks till Inauguration Day. So we're in a pregame mode, and then there'll be a mad dash known as the first 100 days. So with that, I'll hand off to my colleague Scott.
Yeah, sure. Thanks, Jim. And Chad, just to add to your question, at Crowell and Moring, as Jim and I can illustrate today, we have a bipartisan team at Crowell and Moring. We cover both sides of the aisle. We have House Democrats, Senate Republicans, Senate Democrats. But we also have a team that covers a number of different industries. Much of our team is a healthcare team, comes from a healthcare background like Jim and I do. So we do a fair amount of healthcare work within the group, and at any given time we're working on a number of different healthcare issues. Specific in our healthcare work, we have a particular focus on pharmacy supply chain, pharmaceutical supply chain, representing companies and organizations all across the supply chain. So we keep close tabs on pharmacy issues and pharmaceutical issues.
Just a volley. It feels like healthcare, particularly PBM reform, is bipartisan. Like, we saw them line up at the end of 24. I don't know if you can comment, was that more of the new administration didn't want the old Congress to get a win, or what was the dynamic there that pulled it back? And then what does it look like getting set back up in the new administration? Is that a fair question?
Well, part of what impacted whether or not PBM reform went last year really came down to the scope of the spending bill that Congress negotiated towards the end of December. For a while, they were running toward an omnibus spending bill that would cover the entire remainder of the FY25 fiscal year that runs now through September 30th. There were a number of Republicans and Democrats ready to do a full year spending bill in December. There was a little difference of opinion within the Republican Party. Incoming President Trump had his own opinion on how much spending they need to do, or if they should wait until after he's inaugurated. Had they done a full year spending bill and done a full year of Medicare extenders in that bill, as we saw with the initial bill that was proposed, PBM reform would have most certainly run along with that, because it's a pretty attractive pay for. Saves at least $1 billion to the federal budget each year, and probably more depending on the scope of what they put into it. So it really was more of a question of how big the spending bill was going to be. But it is sitting there, still ready to go. PBM reform's a bit of a unicorn in Washington these days, in as much as it gets a tremendous amount of bipartisan support. It's almost unprecedented in Washington today to see that kind of bipartisan support for something as sweeping as PBM reform would be, and that coupled with the savings attached to it make it a really attractive piece of legislation that will. It's not a question of if, but when it moves.
Yeah, I was just going to ask to define it a little bit more. So, we've had lots of versions of PBM reform, and most of them seem to be, I guess, very, very insignificant as far as what it really is going to do to the PBMs. What they're really good at is, fine, you're going to take away DIRs, we're just going to shift over here. Our margins aren't going to change as a PBM, but, go ahead and make those changes. And so what I was really hoping for, there'd be just clear transparency at minimum. So the curtain is pulled back, and the Congress and Senate can see all the stuff that PBMs are actually doing, all the inappropriate practices that they're actually doing, and how they're raising prices and keeping most of that for themselves. Do you think that if and when there's a PBM reform, that it will actually be significant enough to really make change, or is it just shaving a little bit off the top?
I think so. I mean, I think if you look at what happened at the end of the year last year, there were 3 versions of the continuing resolution, the CR. And the second to last, the one that almost passed, that was the one where it was ready to go, and then Elon Musk said, nope, I don't like that. And then President Trump said, you know what, I don't think I like it either. And then the Tea Party folks said, we don't like it because it's spending too much money. And so they took this and shrunk it. But before they shrunk that second to last bill, I mean, they had a number of the PBM reform provisions in it. I mean, they had the transparency provisions in it. They had the spread pricing pieces in it. They had the delinking, of basically revenue from drug prices to bona fide services. So I don't think there's a fight over the policy piece. To me, there's sort of 3 buckets in Washington at all times. There's power, politics, and policy. This one is ready to go. This is like a plane sitting, waiting for the tower to say, okay, you're good to go to take off. The problem is you can't take off until all 3 of those align. In December, the power and the politics did not align. In terms of the power, you had Speaker Johnson, who knew, because it was after November the 5th, so he knew the results of the election. He wasn't going to have any more than 220 votes in this new 119th Congress that was sworn in last Friday. He needs 218 to become Speaker. He couldn't afford to lose more than 2 or 3 votes. So, I mean, his mantra was that the less, the better. I want the simplest bill humanly possible. So it was not that he didn't like the PBM reform piece, why he wouldn't agree to it. It's just that once there was the fight over it, it was done. There was the political piece of it where, once President Trump leans in, then we're going to see this a lot in the coming year. It gets more complicated on the Hill because the Speaker wants to do what the President-elect wants to do. And then you get these other members in the Tea Party, et cetera, that are not sure. So I think PBM reform is going to face that issue this year as well. There's 2 sort of different macro questions. Is the policy ready? I think it's ready. And I think that CR said it's ready. Will the politics and the power line up? The other thing that's getting really interesting is PBM reform. They talk about pay-fors in Washington. If you spend $1, you're supposed to come up with basically another $1 to pay for it. Well, PBM reform would provide some dollars, and will that pull it into the table, or will it wait till later on? The first 100 days is going to be focused on this budget reconciliation bill, taxes, maybe tariffs, et cetera. And the healthcare piece will probably be Medicaid cuts. But with regard to PBM reform and other policy issues, it's very likely in my mind they're going to wait until they'll be the fifth plane to take off, not the first, second, third, or fourth.
Yeah, and I would just add, Tom, when we think about PBM reform writ large, there are really two pieces of it, and you touched on both those. One is the cost savings, the other is the transparency. So cost savings provide the obvious immediate benefit, things like spread pricing, delinking service fees. Those provide an immediate savings to the federal government and to Medicaid programs. But then there's the transparency piece. Transparency piece really serves the longer term policy and fiscal policy, not just healthcare or pharmacy policy, but fiscal policy too. So Congress recognizes the opaqueness that they're challenged with. And so transparency is a key part of that. So there are regular, specific, and strict reporting requirements that were included. It's all in the name of the bill, the Lower Cost, Lower Cost, More Transparency Act, because they know they need that information in order to make informed decisions moving forward. This will be just the latest step in Congress's efforts to rein in PBM practices and to gain a better understanding into those practices, but it will not be the last step. Yeah. And the incoming chairman of the House Energy and Commerce Committee, Brett Guthrie from Kentucky, has already said they're interested in delving further into the PBM issue to ensure that they may miss a few things in the next iteration. But they want to be equipped to do round two whenever that may come.
Yeah, I mean, we saw with Ohio a few years back when they exposed what PBMs were doing to Medicaid program, and now more and more states are doing that. But, what I found most shocking is when the FTC said, hey, we want your information, and PBM said, nah, no thank you. You're like, this is a cartel. If they could sit there and tell the federal government, I don't think so. That alone should tell everybody at Capitol Hill, we've got a problem here.
Yeah, absolutely. I mean, look, in the federal government, we don't tolerate that level of opaqueness and that lack of transparency. We don't tolerate that among federal contractors.
Right.
We require great transparency for anybody that does business with the federal government. This is a relationship that should be approached no differently than that, and Congress gets that. They understand it, and that's what they're striving to do.
Good.
From a long-term care pharmacy perspective, since that's, who we represent, how does that fit? Like, I know we're focusing in now from this big topic of PBM reform down to long-term care pharmacy, or maybe it's better described as services for an older adult population. So at-home services that might be better served with pharmacies that are equipped to handle older adults. How does that fit into this, or does it fit into this? Is that more of a market issue, or is that something that government or that this administration might take up, either on a policy perspective or from a legislative perspective?
Well, I think that let's start from a reimbursement perspective. I mean, Republicans have been clear. They want Medicaid cuts. They want it now. And even though the mechanism, at its worst case, it could be basically caps, it may be something less than that. And even though it's not specifically targeted at them, it's going to hit, SNFs and ALFs, and it's going to hit Part A at some point, and that's going to hit the Part Diem, and that's going to hit the piece basically for the pharmacy. So it's all basically going to flow downhill at some point if they get it, and they want it. And I think at some point they're going to get some cuts there, and that's going to play itself out. I think for there's a couple of different things going on. First, as I mentioned before, healthcare issues in general, including our long-term care issues, are not the top priority for President Trump and the Republicans right now. And I don't say that as a judgment; it's just as a matter of fact. So the good news is, as long as they're not paid for the first half of the year, we don't get hurt. Because when we get hurt is when they see, aha, we want the Medicaid cuts because we want to take that money and use it for something else. Or there's the nursing facility nursing rule, where they'll save $22 billion basically if essentially they repeal it. And they're looking for pockets of money right now to pay for other issues like tax cuts, et cetera. And so the key is almost to stay out of the way for the first half of the year, get past that, and then as you go into the second half of the year, I think that's when you open up the possibilities. Like, what can we do to advocate prospectively for pharmacists? I think that one of the concerns over the years has always been, like, provider status is a good example. You know, you have these bills that seem like are a great idea. You get universal support politically, and absolutely you have the number of votes that you need, but you run into the money machine. You know, there's a big pay for, you can't pay for it. So I think I think there are some areas in which long-term care pharmacy may get hurt because there'll be decisions made that affect reimbursement. And then I think there are some opportunities after that. The last thing I'll say is, this is an out-of-the-box Trump cabinet, okay? RFK Jr. as HHS Secretary, Dr. Oz as CMS Administrator. There's a good and a bad thing to that. Yeah, I mean, there's a good and a bad. The good piece of that is, you know, for years, pharmacies, you know, and long-term care pharmacies have been beating down the door saying, we're among the most popular providers in America. And yet you won't do what we need you to do to serve our communities and our patients. Right. There may be a more friendly audience. You know, it's sort of counterintuitive, but I don't think Robert F. Kennedy Jr. or Dr. Oz is concerned with the prior precedent here. I think if they think it's the right thing to do, I think they may make the move.
Well, I mean, in general, the senior population, as we talk about on every podcast, is growing dramatically, and it's going to grow by 50% here in the next, you know, few years. So the problem is going to exist regardless of if they do anything about it or not. And so, you know, there's just simply not enough nursing homes to take care of 70 million seniors, and they're going to have to age in place. And now comes the question is, how do you service them? Not just through Medicare dollars, but how? What is the easy access provider, which is the pharmacist?
Absolutely, and that's the market dynamic that you were talking about, Chad, because obviously the federal government is going to have to lead the way on this by changing Medicare policy and Medicaid policy. But those market realities that you're talking about, the demographic realities, it's unsustainable if you're looking at a brick and mortar type model. So this is really a discussion that's been going on in the federal space since the passage of the Affordable Care Act. So we're almost 15 years into this long discussion about how we provide care to our senior population and how we best leverage our federal dollars to do that. Provide the best quality care in the best setting possible. Because I think we all know, we know it from our own work, we know it from our own families, people prefer to age in place if that's possible. So if they can manage their medication, if they can stay healthy, the best place, the most cost effective, and the most clinically sound place to have that happen is in the home. So the greatest opportunities, and long-term care pharmacists understand this better than anybody, the best opportunities are in home and community-based settings. Now, that discussion's been going on for 15 years. We've made incremental progress, but it's been agonizingly slow. But the more those demographic forces put pressure on the system, the more we're going to be obliged to do it.
It's like a pressure cooker, right? I mean, it continues to grow and grow and grow. The pressure continues to add onto it, but it almost seems like Medicare almost forgets about all those seniors that are sitting at home. And
there's a lot of discussion about federal spending. So we saw that argument blow up when Congress was debating the continuing resolution. We saw some of those lingering hard feelings manifest themselves in the speaker vote this week. All of that is around federal spending. But it's important to keep in mind the arguments that they are having, the debate they're having on federal spending is on the non-defense discretionary side of the budget. It's not on the mandatory spending side of the federal budget, which far outstrips the discretionary part of the budget. So when you're talking about mandatory spending, you're talking about Medicare and Social Security. Obviously, those are third rails for any politician, particularly on benefits, particularly on eligibility. So we are going to need a DOGE-type approach for somebody to come in and say, we need to leverage our federal dollars better. Now, in some cases, being in a long-term facility is the only option. But for many, many more, there are other options, again, that are more cost-effective and more clinically sound.
So as you talk about, you brought up Medicaid cuts, being more efficient with dollars. Should providers be thinking about what kinds of regulations are the most costly for them to leverage that against any potential pay cut that they might receive? In other words, you can pay people less, but they'll just stop doing the work. But if you say, all right, we're going to pay you less, but we're going to take away this onerous regulation, and no one's regulated like nursing homes are regulated, they're most regulated. Should they be thinking about those things? Like, hey, maybe pull this off our plate. I mean, the staffing never happened, so it's hard to look at it that way, but it's kind of an example. Like, you were going to have to do this, we're taking it back, we're going to save all this money. There's other things that are potentially out there. Should they be thinking about that?
Yeah, I mean, President Trump in his first term was the most transactional president, I think, in American history. Now, he had a pandemic, so they had to be transactional. I mean, I know, and we had clients who, like individuals at the White House, Peter Navarro, others would pick up the phone and say, hey, if you can get 100,000 gowns to New York today, I'll give you a federal government contract. Or, it was like literally wheeling and dealing, If you can make the case, I mean, now is the time, if I was running a large SNF or a large ALF or working with their, they have great trade groups as well, I would go to an Avalier or something like that and do the analysis and come in and say, look, if you could get rid of the following 5, 6 rules, you can save me X dollars. Those dollars will go to patient care, and they'll make up for the Medicaid cuts that you are going to deliver to me because you want to do that. And I think you'll get a friendly audience, frankly. Ironically, I think you'll get a more friendly audience than you would have gotten in the Biden administration. Biden administration was a more typical administration, square peg, square hole, we play by those rules. I mean, this is going to be a round peg or a square peg in any hole, administration. So I think it is a good opportunity. The problem is, it is correct, obviously Medicare, as Scott said, and Social Security on mandatory spending, but it's to some extent a a zero-sum game, unless basically you add more dollars. And this is not an administration that's going to necessarily want to add more dollars, so somebody wins, somebody loses. If you can figure out a way to, let's say by getting rid of regulation where you save money, but you're not necessarily hurting somebody else directly, that's probably a better proposition. And at home, I see it in SNFs that I am aware of that are decreasing beds right now. They want the 21-day rehab bed, but the Medicaid bed, for the patient who's the long-term patient, that's over. It's not there. The money's not there.
CMS has always been we're going to catch you doing wrong and penalize you for it. But, if they can shift over to, hey, we're going to reward the people that are actually doing a good job, I think you'll get better care, and then, not have to sit there and spend all that money on regulations. But that's a whole culture change, but it's always been I'm going to catch you doing something wrong and penalize you, fine you for it.
So is it reasonable, I'm trying to be creative on the fly here, but is it reasonable to say, I'll say something broad, if we went and said, hey, all the medication management regulations that exist in nursing homes, if we took those away and just made them the responsibility of the pharmacy, we would save this much money, and if you just gave us 10% of this much money that you saved, we could manage that instead of the federal government managing that. Is that a reasonable thought process? It does add a little, but it's also sort of designed to pull back some of even the federal spending on CMS personnel and management.
Yeah, I think there's a way to do it. I think you start by using CMMI. You start you have the institution there in CMMI. You go to a Dr. Oz, you say, look, we have an idea. It's like a pilot project essentially, but we think if you start this through CMMI, you run it for a year, you test it, run the numbers, run the math, and then you get a win, and then you prove that the proposition works, and then you go from there. Even in this administration, I would submit, to make it a broad change across the board is difficult without at least some initial pilot project that proves that the thesis is correct.
Yeah, what Chad, what you and Jim are talking about is an ACO type model for long-term care.
Yep.
Where you bring all the players to the table. You have the nursing home, you have the pharmacy, you have the consultant pharmacist, the dietitian, the home health agency. Bring everybody to the table and say, okay, we need to manage this patient population. How can we do it most effectively in a value-based system where we get rewarded for good outcomes, not penalized for technical violations, but rewarded for good clinical outcomes. And you bring that type of model into long-term care, that's really going to put the foot on the gas to transition a significant segment of this population from a facility-based treatment model to more of a home and community-based model.
Yeah.
So sort of an offshoot question along those lines. Do you feel like in this Trump administration, this version, we're going to get more, that the Dr. Oz's and the RFKs are going to get more involved in the bureaucracy? I feel like, since I've been here, and I've been here through Trump 1 and Biden, CMS has been pretty much stubborn, standoffish. We're doing it our way. We don't care what anybody thinks. Are we going to get some sort of change because we're getting new secretaries and influence from this administration, or are we going to be facing the same uphill battle?
Well, we've all seen it in our professions. You tend to emulate your boss.
Yeah.
The organizations emulate the leadership. President Trump's a disruptor, at the risk of a significant understatement. He's a disruptor. He's put a team of disruptors together. If you watched in November and December as he was rolling out cabinet nominees, one of the top talking points on any of these nominees was they're a disruptor. I'd turn on the news and I'd see a Republican member of Congress, talking head, doing an interview. So-and-so's a disruptor. He or she's going to really turn the place around. So yeah, I think he's put together a team by and large that are big thinkers. They're not likely to get mired in the bureaucracy. I don't think they're going to have much patience or tolerance for the bureaucracy, but I think they are incentivized to bring a disruptive attitude to the job, and that means just re-envisioning a lot of what we do in the federal government, whether it's defense contracting, whether it's how we provide health care to all Americans, to seniors, whoever that may be. I think that's going to be a common theme over the next 4 years. And if that weren't enough, now you have the Department of Government Efficiency with Elon Musk and Vivek Ramaswamy, who are going to be sort of the hall monitors, going around the agency saying, okay, are you doing enough? Why don't you consider doing something like this? Now, I don't know that Elon Musk or Vivek know a lot about long-term care, but I do think they could look at some fairly basic metrics and say, yeah, if you have a lower cost setting where patients can thrive, that's where we need to provide the greatest incentive.
I'll say this about Vivek. He's a Cincinnatian. He went to a rival high school of mine. His mother is a geriatric psychiatrist, and I was in her nursing homes and practiced alongside her in my early days of a consultant pharmacist. So it'll be interesting. I don't know anything about what's happened to his mom in the last 25 years, if she's still working, or what influence that had on him. But it's an interesting connection that we learned. Yeah.
So that's a good segue, what you just said, into IRA. So I'll give you my thoughts. Is the Inflation Reduction Act seems like it's a win for America, common Joe America. Yeah, that's good. Stick it to pharma. For long-term care pharmacies, it's pretty devastating. You're talking just the top 10 drugs that they've already selected. We're going to find out the next group here any day now, really, in January, right?
February.
Something like a 23% reduction in our operating profit just from those 10 drugs that's going to go in place a year from now in 2026. So long-term care pharmacy, they're reeling. A lot of long-term care pharmacies are telling me if they're a certain size that they don't know how they can survive past 2026. Then we're going to have another group of 15 drugs in 2027 and another group in 2028. So for us, it seems like they're going after our one profit center, which is brand drugs. But for the government and for regular America, it seems like a win. With that said, being disrupting and changing things and making their own, do you think there's going to be any kind of change in IRA, or do you think that's just a ship that's already sailed?
I think very little on the health side. I think for the most part it's here to stay, despite what you may hear from Republicans on the campaign trail. The political reality is it is popular among their constituents. Whether it's lower out-of-pocket costs, lower insulin costs, just the general notion that pharma is being squeezed. So for a number of reasons, it's popular among their constituents. I liken the IRA health provisions to the Affordable Care Act. And a lot of the cast of characters are largely the same, with the notable exception of the late Senator John McCain, who was a central player in the repeal and replace efforts that were ultimately doomed by his vote. But the parallels are stark. And you have this political appetite among Republicans to roll back a bill that was passed on a party line vote, just like the Affordable Care Act was. You have an incoming Republican president. You have both chambers of Congress under Republican control. I mean, we've seen this movie before. This is exactly the way we were positioned in 2017 when Congress was considering repeal and replace. We all know how that worked out. And maybe somebody proves me wrong, but I don't see any different result coming from Congress. Now there's a whole other part of the Inflation Reduction Act related to energy provisions that may get tweaked and may get some changes. But on the health side of it, I don't see many, if any, changes at all.
I agree, but I think the play is to, you have to give them, you have to go to Capitol Hill and give them what they want. If today they want chocolate cake, give them chocolate cake. Tomorrow it's vanilla ice cream, give them vanilla ice cream. They want to hammer and repeal the IRA provisions, et cetera. And even, and the Medicare drug price negotiation provision is popular. So you don't want to go at it that way, I think. What you want to do is they want a big tax bill. They want to extend TCJA, the 2017 tax bill. So I think you have to think in terms of, is there some way to make back some of this money for long-term care pharmacists? Can we get a new tax credit, for example? Is there a new tax provision? I mean, I think if you come selling that, you lose $1 over here and you can sell over there, and you don't interfere with what they're trying to do on IRA, but you feed into what they're trying to do on taxes. I'm not saying that it's, that I
but be creative.
Pass next week, but I think you want to be creative. You want to feed, and I think this is why I think the Trump administration really creates opportunities. And I'm a Democrat saying this, but I think if I'm sitting in the business community, I don't care what your business is, but particularly in a business like long-term care that directly affects patients, you can make the case. The other thing that's going to be really interesting about this administration is the president. You may recall in the first administration, the Oval Office was sort of wide open. I mean, people coming in this way, they're coming in that way. I mean, he was talking to people all day. I know from friends who know the president that he loves to talk to people. He wants to pick up the phone and ask, what do you think? What do you think? What do you think? What do you think? If you get into his head an issue, like, Mr. President, long-term care pharmacists are really being hurt here. That's not what you really want to do. It's bad for a lot of the folks in Florida, now your adopted home state. Why don't you think about doing the following? A tax provision or whatever. You can cut quickly through the system. It goes back to, I think, Chad's question. Can they turn the system upside down? If you're RFK Jr., or if you're Dr. Oz, you're going to have 3 or 4 shots at the title. The system is strong. The institution of the federal government is resilient. Okay, it's like a fight between an antibiotic and a bacteria. Like, the bacteria adapts. It's going to fight back. It will catch up with the antibiotic at some point. You need to strike early in the first year and say, these are the 3 things we're going to change here. I don't care if I have to walk door to door through the whole institution myself. But if you don't do it in the first year, by the time you get to year 2 and year 3, the institution, its defenses are strong, and it's going to be much more difficult.
Yeah, makes sense. I think one of the best things that Dr. Oz could do is to name a chief pharmacist, which has never been done. And I'm going to nominate Chad.
Yeah, right.
Amen.
Jim wrote that little piece of legislation, chief pharmacy officer for CMS.
It's a no-brainer.
It sits there, but it's a cost.
Yep.
I'm sure any office in CMS is a cost, but I guess that's how the dentists got one. So
yeah.
Maybe we should get one.
But they need to be a long-term care pharmacist that's dealing
They
with
definitely
Medicare
do.
patients,
Yes.
not another
I have
pharmacist.
some other names in mind myself.
Oh, you already live in the neighborhood, so that's an easy drive.
Yeah.
You can do both jobs.
One last topic. What's the impact of the United Healthcare CEO getting murdered? Is there an impact on healthcare? Does that create a conversation that we haven't had? We talk a lot about healthcare has evolved to the point where it's a system of denial. It's, you're not getting this surgery, you're not getting this medication. These companies are starting to feel the public pressure of, every time I engage, I'm told I can't have. Whether it's, you know, the new GLP-1 drug because it causes you lose weight. Like, they're constantly running into this. How is that philosophy going to influence healthcare in an environment where you do have limited dollars to spend?
Yeah. Well, it's a horrible tragedy. I think it's going to have profound impacts in a number of areas, not the least of which is just basic security for high-profile executives. I think it's also going to have it seems to me, knowing the facts of that case as we do, it's as likely to have an impact on mental health policy as anything. But to the underlying question, it sort of goes back to a term I used earlier. It's an unsustainable system where we are right now, and it's a system of scarcity, particularly when you're talking about federal healthcare services that the federal government pays for. It's a system of scarcity. It is a zero-sum game. In fact, it's less than that. There aren't enough dollars in the system today to pay for the services that we need. And yet nobody's talking about significantly adding to it. In fact, just the opposite. So yeah, something's going to have to turn around. Part of that's innovation. Part of it is just leveraging dollars better. But another part of it is making significant investments in the short term that yield results in the long term. It reminds me of any breakthrough medication that comes out. I mean, take your pick. You know, you get a medicine that cures hepatitis with a big list price. Nobody wants to pay for that in the short term, but they also want to avoid the long-term cost that drug helps to avoid. So it is a somewhat of a broken or upside down system that's going to have to be closely examined.
Yeah, I think it highlights an important point. Obviously a terrible tragedy, and we feel terrible and very sorry for his family. But the point it highlights is the power of social media and how long-term care pharmacy, as exhibited by the fact that we're in a room now doing a podcast from your headquarters, can leverage that, particularly in this administration. If you look at the reaction afterwards, the reaction, you know, before it got to the media, across social media, there was the beehive had been hit. The anger towards health care companies came out in the reporting and the comments to, you know, on Twitter, you know, Facebook, et cetera. And that made its way sort of around the country, like very, very quickly. If we take out of it, you know, take it out of a scenario where somebody gets murdered, but if there's an issue that we really want to push, or we want to get to the attention of, you know, President Trump or his team, I mean, he is going to be the president of the United States again, and he definitely has people who help him with his Twitter or X account, but he also clearly personally looks at it every day.
Right.
I mean, if you get into that feed, you know, and then you add to that the fact that he makes very personal decisions where I like X and I don't care that everybody else on my team likes Y, I'm going to do that. You saw that in the pick, for example, of Matt Gaetz as his attorney general. I mean, the story went around, which has pretty much been confirmed, which was he was on an airplane in one compartment of the airplane, and he was persuaded, okay, I'm going to go with Matt Gaetz as my pick. His chief of staff was in another compartment of the airplane, and he never even talked to her. He just put it out. He just put it out on social media that he was going to do it. So I think that what I took from that is that one episode, terrible tragedy, you know, can trigger the population on social media and can have a political outcome. Right. And in this next administration, almost certainly there's going to be, especially given Elon Musk's role now.
Absolutely.
There's going to be some issue that's going to annoy Elon Musk or something.
And he's on Twitter as much as anybody. So.
Constantly. Yeah. You know, when we get past whether we're going to buy Greenland or whether we're going to annex Canada and all of that, and we get to actual healthcare issues that matter, I think it's going to be powerful.
That's good stuff.
That is good stuff. Well, I appreciate you guys spending so much time, and all the times you come and speak to our membership. It's just super insightful. And it really provides some insight into what goes on over there across the Potomac that is so difficult to articulate and sort of navigate. So we appreciate your help.
And
Thank
both of
you.
you having, long-term care pharmacy
I know, it's
background is
Yes,
really
it's phenomenal.
staggering. So yeah, it's
Yeah.
Wonderful.
lucky
Yeah.
to have you here.
Well, we appreciate you having us. As we're recording this, there's a little less than a foot of snow on the ground. So I want to thank you for getting me out of shoveling my driveway this afternoon. So
Well, I heard blowtorches
That's right.
work really
It's a good
well.
idea.
Just melt it right off.
yeah,
So.
Yeah. And we greatly appreciate all the long-term care pharmacists out there that I know you do a great job representing. And we appreciate you and all the great work you do. And Chad, you've done a lot of great work on Capitol Hill and really raised the profile of the organization over the last couple of years. And we appreciate all that work.
Yeah. Well, thanks, guys. All right. We'll see everybody next time on the next episode of Our Experience.